All right, our next speaker is going to be Rimma Shaposhnikov. She received her medical degree from SUNY Buffalo and then did her internal medicine and gastroenterology training at the University of Southern California. After she completed her training, she joined a practice in the San Fernando Valley, and about a year ago, we were fortunate enough to recruit her to become the first gastroenterologist at UCLA at our Northwest campus in Thousand Oaks and Westlake Village. Today, she's going to talk about constipation. Where are we now? Rimma.
Good morning, and for all of you who drove out from the valley, hopefully you had no traffic like I didn't, which was great. Okay. So I wanted to mention briefly some of the things that I'm going to talk about today. One of them, of course, is the prevalence and the economic burden. We hear a lot about Obamacare. I just want you to know where your money is going for. Some of the new changes in the definition of constipation, the subtypes that we have available, the diagnostic evaluations, of course, and the treatment options. So the direct annual cost, and this is actually a study by Lynn Chang here at UCLA, done almost 10 years ago, showed that at that time the direct annual cost is $1.6 billion, and that involved 500,000 inpatient hospitalization for constipation and the side effects of that, as well as over 3 million office visits. Notice on the numbers of how many patients are actually seeing us versus seeing internal medicine and family practitioners. 1/3 will see family practitioners, 20% will see internists, about 9% will see OB-GYN and surgeons, and really only 4% of patients will see gastroenterologists. So really it is up to you not only to get a great history and find out about these patients, but really you are the first people to offer the diagnostic testing, the reassurance, and of course the treatment. 87% of patients were seen in the emergency room, and the studies vary for medication cost greater than $400 million, and one of the studies that came out recently actually put that number close to $800 million that patients are spending on over-the-counter medications. So the pharmacists are happy. I know none of you are getting a cut of that. So the cost of hospitalization, this is one of the recent studies that just came out less than a month ago. The study by Sethis actually showed that if you looked at the direct discharge, primary discharge being constipation, in patients from 1997 to 2010, that number actually increased up to 48,000. The mean length of hospital stay increased mainly from 3 days to 3.1 days, but still most patients are spending about 3 days in the hospital. I don't know about you, I get a daily email from one of my local hospitals telling me to discharge immediately because there's no bed, so 3 days is quite a bit of a time. And the charges increased up to $17,000 per patient for admission. And as you can see, the total costs were close to $851 million. And again, that data is 3 years old now. The global prevalence, if we use both Rome 2 and Rome 3 criteria, is actually reaching 14% if you combine a lot of studies. It has been shown to be that constipation is more common in women, 17.4% compared to 9.2% in men. Keep in mind that number may be a little bit higher. Not a lot of men do complain about constipation, unless, of course, they're brought in with their spouse to my office. Usually it is higher in patients with lower socioeconomic class. Patients older than 65%, that number jumps up to 33%. A lot of patients will have IBS, as Lynn just mentioned, and it appears to be more prevalent in Western world. Although there's some data from Middle East and Central America, there's a lot of positive data from Africa and Middle East otherwise. So some of the definition of constipations that we use and you're familiar with, of course, is the Rome 3 criteria. That's that functional versus IBS-C. There's actually new data from AGA that they want us to look at the transit time. How long does it actually take for the bowel movement once it reaches the colon to the rectum? All right. And of course, the most important thing is the secondary causes. When your patients come in, the constipation is not usually, but it may be related to secondary causes. So it really is up to you to figure out whether a patient have chronic idiopathic constipation or their secondary causes. Some of the specific etiologies that most of you are familiar with: diabetes, other endocrinological issues such as hypothyroidism, hypercalcemia, pregnancy, Parkinson's, MS, spinal injury, and the list goes on. Medications, if you've started somebody on medications or your partner did, it's a good idea to find out when their constipation started, when did that change in bowel habits occurred, because a lot of medications, well known, obviously, like opiates, but antihypertensives, antidepressants, antipsychotics, Iron preparation, always find out what they're taking on over-the-counter basis as well. Aluminum, vinca alkaloids, antihistamines, the list goes on and on. So it is imperative to take great history because secondary causes, you can save yourself and the patient not only a lot of hassle, time, and money. But it's great to play a detective. So if you solve their problem, that their doctor is the greatest. Look at that, right? Lynn already mentioned the constipation Rome 3 criteria. I just want to point the difference between constipation and IBS as it relates more obviously to the constipation. The constipation must include 2 or more: straining during greater than 25% of defecations, lumpy or hard stools, sensation of incomplete evacuation, sensation of anorectal obstruction or blockage, and of course this one question that your patients may not disclose, but if you ask, you may be surprised to find out: manual maneuvers or digital disimpaction. Keep in mind, those are the symptoms that your patients are really concerned about. They really would like not to have difficult evacuation. They might not care that you as a doctor statistically care that patient is having less than 3 spontaneous bowel movements a week. They just want to know when they go to the bathroom that it's comfortable, that they're not spending hours in the bathroom, that they're able to go to their job on time, their interview on time, and have a good play date with their kids. Loose stools are rare without laxatives, and of course there's insufficient criteria for IBS. So just briefly, IBS, as Lynn mentioned in detail, there's recurrent abdominal pain. Notice I did not mention that with constipation. With IBS, it's recurrent abdominal pain or discomfort that has occurred at least 3 times a month in the last 3 months, and it's again associated with changes in bowel habits such as improvement with defecation, onset associated with a change in frequency or form. And of course, you already went through all the subtypes, but the subtype C being the hard lumpy stools occurring greater than 25% of time. I had this great slide, but I thought it was too simplistic. But basically, it showed apples and oranges. Your perception of what constipation is and what your patient's perception of constipation are 2 different things. Now, the only time I think gastroenterologists ever pull out that Bristol stool scale is when we talk about Dr. Oz and when we give lectures. I truly don't have it in my pocket when I talk to my patients. But patients do come in and now with the onset of iPhone, which I would love to chuck, they show me pictures. So aren't you glad you don't have to see that? I get that Bristol stool scale on the iPhone. Doctor, I want to bring it in. They won't let me, so here's the picture. And I tell them the description is really good, but some people just think that picture is worth $1,000. So the chronic idiopathic constipation, keep in mind, consistency is what your patients care about. Am I having pellet-like stools or is it liquid? And they want to give you that description, right? And all you're sitting there as you're writing your note or now typing as you're talking to the patient. Okay, but how many times are you going to the bathroom a week? Is it less than 3? Great. Now you are constipated. Now I need to move on because I might already have my smart phrases picked out. We are thinking about the colonic transit time. As doctors, we're trying to figure out, is that stool, once you've eaten, does it go to the rectum on time? Keep in mind, not every patient has abnormal colonic transit time. They actually may have completely normal physiological evacuation of stool. The AGA, the American Gastrointestinal Society, actually wants you as doctors and us as specialists to really address what we can fix immediately. Because by the time patients see you, they've already spent at least $1,000 with their pharmacist. So you want to know, how long have they taken their medication? How long has it not worked for them? So one of the new algorithms that just came out last year from AGA, as you can see, and I know that, oh, okay, but that just only works for me, okay. So interview and physical exam, that's extremely important. That's where you guys come in. You need to rule out secondary causes of constipation. You want to make sure, yes, this is where the rectal exam done by primary care doctor does occur. You want to do that rectal exam. You want to find out if there's a prolapse. You want to find out if they can sense your finger when they're doing the normal tone. And no, you cannot defer to the gastroenterologist. Consider the metabolic and structural evaluation. You don't have to do anything unless, of course, you're suspecting secondary causes. If you have a 30-year-old female that has not been going to the bathroom more than 3 times a week for the past 20 years, there's probably no organic or structural cause. You don't need to do anything extra. But as you're getting your history and you're considering secondary causes, because she may have something else, this is where your metabolic and structural evaluations will come in. Most of the patients, by the time they have seen you, they've already taken the therapeutic trial of fiber and laxatives. And I'll quickly on the next slide tell you more about it. But Make sure that they've taken 25 to 35 grams of fiber a day. Make sure if they're older, they're actually drinking that water. Nothing like taking the fiber and then going, I'm so bloated and nothing is coming out, the stool is harder. If they're not drinking the water, they're passing rocks. This is the hard one. How long is that inadequate response? Well, it really is individual. A patient may be okay. He's telling you that it's been 3 to 4 months and they're not doing great. I used to be in Burbank, so Motion Picture Hospital is right there. And let me tell you, they have to be on the set in 20 minutes. If they have not pooped before they fly to, on their location, you're in trouble as a doctor because that's really what their goal is. They need to go to the bathroom immediately. So the new part of the algorithm that most of you may not be aware of is that we're now recommending going straight to anorectal manometry and balloon expulsion test. Now, some of you are sitting there going, well, who in the community has this test? Well, UCLA does. However, if it's not, so let me just talk a little bit about that. If it's not available, you can obviously go straight to the colonic transit evaluation. AJA is aware of that. But if you do have an option of ordering an anorectal manometry test, the reason for that is if it is abnormal, you're going to now get straight to that defecatory disorder. And now we'll talk about that in the next few slides. If it's inconclusive, patients may benefit from either barium or MR defecography. Of course, abnormal, we're going back to that disorder. We're trying to make sure that patients do not have something we can fix immediately. You don't want them here in inadequate response for a long time if it's something that we can fix. Of course, most patients will probably have a normal colonic time with normal transit constipation, but some of your patients may have slow transit constipation. All right. So just briefly, the over-the-counter therapy that some of your patients will encounter, the bulking agents, again, up to 35 grams of fiber a day, they may cause bloating. I tell my patients, get to know your pharmacist. There's some agents that will make you feel better versus your husband. So it's okay to try them. It's okay to figure out which one of them works for you. Don't forget the water. Hyperosmolar laxatives work great. In fact, when patients take the PEG solution for their colonoscopies, they go, I have never felt this good. I'm like, I know. They're non-digested, non-absorbed. There's no electrolyte imbalance. But keep in mind that global sensation of abdominal pain, because a lot of your patients may have that abdominal pain, will not be improved. The stimulant laxatives are great. However, again, no global improvement has been shown in IBS or chronic constipation. And it's unpredictable, right? So it's great for a person who works close to home, but not so good for a CEO who has to give a talk. Some of the pharmacological therapy that have now been on the market for about actually greater than 7 years. One of them is Lubiprostone. It has been approved not only in chronic constipation as well as IBS-C, but also the newest indication in the last 6 months has been by FDA for opioid-induced constipation. I listed all the doses. Keep in mind the medication needs to be taken with food twice a day in order to avoid one of the main side effects, which was nausea. It is a prostaglandin E derivative that does activate mucosal epithelial chloride channels specific to the small bowel. It does promote water secretion into the lumen of the small bowel, and again, there's no electrolyte imbalance. The studies show that it does relieve bloating, straining, and stool, and helps with stool consistency, especially improving the number of spontaneous bowel movements, greater than 3 spontaneous bowel movements a week. The second treatment is Alanedyl, which is once a day dose on an empty stomach, all right? And the dose is 145 micrograms for chronic idiopathic constipation versus 290 for irritable bowel syndrome constipation predominant. This one is not approved for chronic opioid constipation. It acts via guanyl cyclase C pathway. It is superior to producing, again, 3 or more spontaneous bowel movements, which is how we define constipation in all of our studies. And it is intestinal transmembrane receptor for both chloride, bicarb, and fluid, the side effects of diarrhea. It appears to be less predictable than the other medication that I just mentioned. But most patients actually would like to have a bowel movement, so they'll take it in any shape or form. So Lynn did a great job already telling you about the alarm symptoms. I just want to reiterate that notice on the AGA diagnostic workup that if we go back, I did not mention endoscopy and colonoscopy. And as much as I want to put my kids through college, keep in mind that this is probably not what you need to do. So if somebody has alarm features, weight loss, rectal bleeding, heme positive stool, family history, sudden unchange in bowel habits or stool caliber, anemia, pain, or an onset occurs in patient greater than age 50, yes, to address those present alarm symptoms, you do want a scope. To offer screening colonoscopies, I'm a huge fan. Please do. But the role of colonoscopy really has very low yield. The study done by Papin more than 10 years ago actually showed that it's comparable to doing a screening colonoscopy, meaning for us to find adenomas, advanced lesions of colorectal cancer, is really comparable to if we were doing your colonoscopy. There's no role in disimpaction. So please do not call or tell your nurse to call us at 3 o'clock in the morning to go to the emergency room. Putting a scope will not help, nor do we want to do it. And chronic constipation is an independent risk factor for poor prep. No surprise there. Your patients are probably not going to be as clean. So we do individualize that. We do talk to patients. We may alter our preps in order to address that. So the big topic of 2013 for constipation has been this dysenergic defecation. So what does this mean? In plain English, it's ineffective defecation associated with outlet obstruction. It is a failure to relax or inappropriate contraction of puborectalis and external anal sphincter muscles. It may lead to narrowing of anorectal angle as well as increased pressure. One of the questions you may ask your patients is when they're sitting on the toilet, do they feel the need to rise or change their angle a little bit? You may be surprised. Some of the patients may have already figured out that they're sitting at 90 degrees angle. They may not have the proper skills to defecate. They may need to move around in order to have the bowel movement. Additional clinical history, patients may be straining even with liquid stools. There's incomplete evacuation, digital disimpaction, and of course they feel better after enemas or suppositories. They have a sensation that something is stuck and it's not coming out. The Rome 3 criteria for the functional constipation is paradoxical increase in anal sphincter pressure, less than 20% relaxation of that anal sphincter pressure, as well as inadequate propulsion forces seen on either manometry, imaging, or EMG. And Dr. Rao, one of our big gurus in the field, actually added 3 more. Inability to expel balloons. So if you do have a rectal balloon, which is about 50 mLs of liquid in it, if you cannot expel it within 1 minute, chances are you have dysenergic defecation. If the prolonged colonic transit time is greater than 5 markers, and I'll show you that study in a little bit, as well as an inability to evacuate, or if patient has greater than 50% retention of barium during defecography. So some of the tests that have been recommended that we do have available, one of them is the anorectal manometry. We're able to assess the anal sphincter function both at rest and during defecation. We're able to measure the anal sphincter pressures, rectal sensation as well as compliance, reflexive relaxation of that internal anal sphincter, as well as response to biofeedback, which is one of the therapies. We now have 3D manometry, so with the use of 256 circumferential transducers, you really are getting a great picture of what is going on, and the patient is able to actually lie there and see it alongside you. One of my least favorite tests to recommend, as I beg my radiologist to do it, is the defecography. So not only are we able to look at the anatomical and functional changes of the anorectum, it actually is a great tool for both enteroceal and enterosusception. It is able to assess that anorectal angle both at rest and during expulsion of barium. But you've got to sit on this little chair in a little gown in a very cold room, and the radiologist tech keeps coming in going, are you pooping? Are you doing okay? So, the comfort level is probably not there. So the radiologists don't like to look at poop either, so now they have the dynamic MR for the whole pelvic floor evaluation, and that both the patients and apparently the radiologists seem to enjoy that a lot more. The pelvic floor dyssynergia, you're able to diagnose that, especially if there's insufficient descent to the perineum, less than 1 centimeter, or greater than 50, and less than 15% angle change. And of course, the rectocele greater than 4 centimeters is considered significant. The colonic transit studies, there is not a true protocol. A lot of patients will use a Metcalf protocol. We find that this is one of the SITS marker protocol appears to be one of the simplest. You ask the patient to ingest on day 1 a single capsule with 24 markers, and on day 6 you order a routine X-ray or KUB. So after 120 hours, you monitor the retention of those markers, and any greater than 5 markers is considered abnormal. You're able to monitor whether the markers are in the right or left colon, and of course, if there's stagnation in the rectum, that may pinpoint the outlet delay. The limitation of the study is, of course, the patient has to be off those laxatives for 3 days. So I had recently a patient who decided to change a little bit my modifications and decided to be just on liquid diet and not eat, because she said, well, I'm going to be uncomfortable. You're telling me not to take laxatives. So although that she passed the test, I'm not quite clear how I can tell her that it was normal or abnormal. Their results may be suboptimal if there's impacted stool, and of course, there's not a true standard protocol just yet. Additional studies, again, a little plug for UCLA, that are available here. We have Smart Pill, which is a new wireless pH and pressure recording capsule. It may record up to 4 to 5 days, usually consumed after a standard meal, able to evaluate the entire gut transit time, and it has been validated against radio pack markers as well as gastric emptying study. Of course, a tiny little limitation. It is a bit expensive. So some of the treatment algorithms in the same paper from AGA, if somebody does have normal or slow transit constipation, they're perfect candidates for that laxative. If there's improvement, continue the regimen. You may notice that patients will tell you, this medication worked great, and then it stopped, right? And we get a lot of that. I tell patients to keep a little diary. Come back to that medication. If that worked once, it will probably work again, and it's okay to alternate some of the over-the-counter medications. If they worked, they may stop, and again, they will work in the future. Each person is different. However, if there's no improvement, you will consider modifying the regimen, consider adding the new pharmacological therapy that I just mentioned, and of course, again, if there's improvement, continue. If there's no improvement, this is where you may consider checking their colonic transit test on medications, seeing if it's delayed or normal. Of course, if it's normal, all you need to do is adjust the medications as needed. And if it's delayed, consider actually checking if patients have delayed gastric emptying. If it's not just colon, if it takes longer from mouth to anus, that may be beneficial as well. If patients have normal gastric emptying, this is where you may consider doing additional studies such as colonic manometry or Baristat studies. If they're abnormal patients, this is the patient that would be ideal to send to a surgeon to discuss the subtotal colectomy as well as ileorectal anastomosis. However, if it is normal, your surgeon may offer a temporary loop ileostomy to figure out if that works for them. Some of the, just briefly, subtype-specific therapy that we have not addressed are biofeedback therapy, which have really strong recommendations. This is for your dysenergic patients, that outlet obstruction. It is indicated for paradoxical pelvic floor as well as anal sphincter contraction. It is a non-invasive means of cognitively retraining the pelvic floor as well as abdominal wall musculature. Not every center has that available, so just make sure that somebody is qualified to offer biofeedback. And of course, the subtotal colectomy with ileorectal anastomosis, I don't want to say it's the last resort. Some patient will ask for colectomy, but make sure they're appropriate candidates. Of course, those are the patients who have failed standard therapy, have abnormal transit time, in the absence of either pelvic floor dysfunction or upper GI motility issues. Keep in mind that although patients love defecating, if they have not had that opportunity beforehand, the abdominal pain and bloating may persist. So, as internal medicine doctors, this is critical to obtain the history. It is critical to do a good physical exam, rule out secondary causes, of course, test for etiology if medical therapy fails, have appropriate goals with your patient. Beheading somebody is probably not necessary in order to achieve your goal. Thank you very much.